In this class, we are going to talk about the malformations of cortical development, which are infrequent, but found in 25% of epileptic children and adults. Throughout the development of central nervous system, we will find three overlapping phases: proliferation, migration, and organization. These three phases are produced since 7 weeks of gestation to achieve a correct development of the cortex with 6 organized layers. When we find a defect in the proliferation phase, we could have a descent of the proliferation, which will lead to microcephaly, or an increase, or apoptosis failure, which will lead to microcephaly, hemimegalencephaly, or tuberous sclerosis. When there is a defect in migration, we could find two types of anomaly: lysencephaly or heterotopia. And finally, when there is a defect in the organization, we could find polymicrogyria or schizencephaly. The evaluation of the cortical development can be done through ultrasound by assessing the appearance of fissures, which are sylvian, parieto-occipital, calcarine, cingulate, and temporal superior. We should assess not only its appearance, but its morphology as well, because this could tell us the maturity of the cortical development. This assessment sometimes can be difficult for ultrasound. In this subject, the MRI has a lot of advantages, although it has less space resolution, allows to see correctly the cortex throughout the pregnancy. The ultrasound allows to see the cortex until 26 weeks, but after that gestational age, when the cranium is more ossificated, the shadows of the ultrasound doesn't allow us to see the cortex, and with the MRI, this can be well assessed. Let's talk about the proliferation anomalies. The cephalic perimeter is the ultrasound marker that will allow us to make the diagnosis. If we find a cephalic perimeter under 3 standard deviations, we are facing a microcephaly. On the other hand, if it is above 3 standard deviations, we are facing microcephaly. We have to take into account that micro and macrocephaly are ultrasound markers of primary or acquired anomalies, and as a marker, we will have to look for the underlying pathology that is producing this alteration. Microcephaly is produced in 1 in every 6,000 or 10,000 births, can be primary when it's associated to genetic syndromes as Smith-Lemli-Opitz or Meckel-Gruber, or specific chromosomal anomalies, or can be acquired secondary to infections as cytomegalovirus, toxoplasma, toxics as alcohol, or severe maternal diseases. Here we can see that from all microcephaly cases, more than half of them are related to central nervous system malformations. 25% of them are associated to some unspecific central nervous system anomalies, 10% to cytomegalovirus infection, and a small proportion a normal evaluation. We must highlight that those with central nervous system malformations or an specific anomaly will have an impaired neurodevelopment in a variable degree. Which will be the advisable evaluation when finding a microcephaly? We should make a neurosonography. We should look for central nervous system anomalies, a detailed morphological ultrasound, karyotype with the study of specific mutations, serologies of cytomegalovirus and toxoplasma, and also study of specific pathology as is the Smith-Lemli-Opitz. And what is the image seen in microcephaly? We will see it typically from second trimester of gestation, and it is typical to see a frontal flattening due to the hypoplasia of frontal lobes. In case there are underlying pathologies, we could find, for example, calcifications in the case of infections. If it is a Smith-Lemli-Opitz, we will see corpus callosum agenesis or holoprosencephaly, or we could find encephalocele or cerebellar anomalies in the case it is Meckel-Gruber syndrome. Microcephaly can be primary or secondary. Primary microcephaly have different causes. One is the benign familiar. Others that have macrosomy, as the Sotos or Weber syndromes, skeletal dysplasia, neurofibromatosis, or Fragile X. And the most frequent cause of secondary macrocephaly is the hydrocephaly. Regarding the primary macrocephaly, the most frequent one is the benign familiar, representing 50% of cases, having an autosomal dominant heritage, exists a previous familiar history, is 4 times more frequent in male than in female, has an increased subarachnoidal space, and has a good prognosis with a normal IQ. And how do we see it? With an increased subarachnoidal space. In case of macrocephaly associated to other pathologies, as the hydrocephaly, we can identify a severe ventriculomegaly, or in the case of a skeletal dysplasia, we could see a prominent forehead. Which studies should be asked when facing a macrocephaly? Neurosonography to look for associated intracranial anomalies, detailed morphological ultrasound. We should assess the familiar appearance to rule out the familiar macrocephaly, perform karyotype when suspecting macrocephaly associated to any syndrome, and also the specific study of suspected pathology. Other entity diagnosed through the detection of microcephaly is the hemimegalencephaly, which is due to the overgrowth of one cerebral hemisphere, can be isolated in 50% of cases, and in the other 50% of cases is associated to neurocutaneous syndromes. It's a severe pathology associated to seizures, hemiparesia, cognitive impairment, and hemihypertrophy in the rest of the body. And how are we going to see it? We can see through ultrasound or MRI. We will see increased volume of one hemisphere. Severe ventriculomegaly is associated to abnormalities in the cortical pattern and cortical thickening. Other entity found in proliferation defects is the tuberous sclerosis, which consists in multisystemic hamartomas, has an autosomal dominant heritage with heterogeneous penetrance, and 70% of cases are de novo, have severe neurological symptomatology with seizures and cognitive impairment, and can be also associated to extra central nervous system symptomatology, which are the cardiac rhabdomyomas. The ultrasound detection is difficult, although sometimes the hamartomas can be seen in the cerebral parenchyma. So in this case, the MRI will be useful to diagnose not only the cortical tubers, but the ependymal as well. In these cases, the spectroscopy can be useful. Now we will talk about the migration anomalies. The migration of the neurons proliferated in the periventricular area are produced in 2 phases. In the first phase, the migration produces the migration limit, called Pial-Pripyat, and the second phase of migration has several waves of cells that will produce the layers of the cortex until 6 layers are formed. Which is the mature cortex? If there is a problem in the first phase, can lead to a type 2 lissencephaly in which the neurons migrate further than the limit established, until the meninges. If there are anomalies in the second phase, can lead to a lissencephaly type 1 in which the neurons don't arrive to the cortex, so an ogyria or pachygyria 4 layers cortex are produced, in which the neurons are accumulated in periventricular nodules, cortical or in bands. Lissencephaly type 2 can be primary due to specific mutations or deletions, for example the Walker-Warburg syndrome, or secondary to hypoxia or infections. In the same way, the lissencephaly type 1 can be primary due to specific mutations or deletions such as Miller-Decker syndrome or linked to chromosome X, or secondary to hypoxia or infections later on in the development. Although the 2 types of lissencephaly have different origin and causes, the ultrasound evaluation is very similar. The guide sign will be ventriculomegaly, which will be accompanied by delayed or absence in the appearances of fissures, as you can see in this video. Here we can see the Sylvian fissure in a 32 weeks fetus, which is immature for the gestational age, As we can see in this image, on the right side, in the coronal section, we cannot identify the parieto-occipital fissure compared with the normal appearance of it at 32 weeks. And in the sagittal section, we are unable to identify the sulcus, which should be identifiable, as you can see in the image. Facing the ventriculomegaly and the delay or absence of fissures, we can make the diagnosis of lissencephaly. MRI can be useful as well. On the bottom, you can see the normal images corresponding to 32 weeks, and these are the images seen on our fetus with 32 weeks. There is an evident difference in the cortical pattern. The ultrasound can also help us identify the type of lissencephaly. For example, in the Walker-Warburg syndrome, we can also see the associated anomalies in the corpus callosum, the brainstem, and cerebellar anomalies. Therefore, if we find the corpus callosum agenesis, we will think on a lissencephaly type 2. Nevertheless, in the Miller-Decker syndrome, we will find congenital heart diseases, omphalocele, IUGR, or genitourinary malformations. Therefore, the ultrasound will help us to first to identify the lissencephaly and second to guide it if it is type 1 or 2. Therefore, when facing the suspicion of lissencephaly, we will indicate a neurosonography, a detailed morphological evaluation, and eventually a karyotype to guide if it is a type 1 or 2. However, the prognosis of both is poor, with a high degree of cognitive impairment. Other anomalies is heterotopia. This can be primary, which in the majority of cases will be sporadic or due to specific mutations, or secondary due to events that will produce brain damage throughout the gestation. In 40% of cases, the symptom will be an untreatable epilepsy, and we can have three types: the subventricular, cortical, or in bands. But in fetal life, we are only able to diagnose the subventricular, because the other two give difficult images to detect. And how are we going to identify it? In this ultrasound, you can see here in the edges of the lateral ventricles, there is a serrated edge. Here in the movement, and here at the right in an ultrasound, and below in an MRI. This last one will help us to identify the heterotopic nodules suspected in the ultrasound. Finally, let's talk about the organization anomalies. Here we find a defect in the connection between the layers, and there are two types. Polymicrogyria, in which there are small anomalous sulci, or the schizencephaly, in which there is a cerebral tissue disruption. And here we find two types, as well the open lip, where there is a communication between the ventricles and the subarachnoidal space, and the closed lip, in which there is no communication. In these cases, the MRI will be very useful in the diagnosis because in a high proportion we are not able to detect it with the ultrasound. MRI has a sensibility of 85% for detecting polymicrogyria and 100% in schizencephaly. Polymicrogyria can be primary or secondary. In the primary case, it can be isolated or associated to genetic anomalies. The secondary is due to infections, hypoxia, vascular anomalies, or teratogens intake. It has a large spectrum of manifestations. They can have a mild cognitive impairment, motor dysfunction, epilepsy, or even suction and respiratory difficulties. And how are we going to see it? A small anomalous sulci, which can be in any cortical location, are difficult to detect in the ultrasound, and as we can see here in the MRI, are small serrated edges, which doesn't correspond to the normal sulci compared with the normal standards with its gestational age. Usually, it is associated to other central nervous system anomalies. The other anomaly is the schizencephaly. This can be primary in the context of genetic syndromes or secondary in the context of hypoxia, vascular anomaly, teratogens, or infections. The symptomatology depends on whether it is unilateral or bilateral. In the case of unilateral schizencephaly, we'll have epilepsy resistant to treatment, and in the case of bilateral, have severe sequelae with severe cognitive and motor impairment. and the epilepsy is infrequent. And how are we going to identify it? We will see a lack of continuity in the brain tissue, covered by cortical layer. This will make us distinguish this pathology from the poor encephaly, and it is also associated to other central nervous system anomalies. In this image, we can see an open lip schizencephaly. The suprarachnoidal space communicates with the ventricle, and in this other image, we see a closed lip, in which there is a defect but doesn't communicate with the ventricle.